Hello, I'm going to be talking about advanced dementia, which is one of the most cruel of terminal illnesses. It can cause huge suffering for patients and loved ones, sometimes for years. Since there is no cure, most people want to avoid a prolonged dying after they reach this stage. That's why it's tragic if loved ones learn that the patient's living will won't work after there is no way to change it because the patient has lost capacity. Another tragedy is to fear this scenario so much that people do what's called pre-emptive suicide. They kill themselves while they still have good life left. This presentation explains what makes living wills effective so there is no need to hasten dying. I'm Stanley Terman. I'm a board certified psychiatrist and bioethicist. In the year 2000, I founded the not-for-profit organization Caring Advocate, which I still lead today. And with help from colleagues and patients, I've been working on creating an effective living will for advanced dementia since 2005. I hope you find this video helpful for you or your loved ones. The presentation's title is The Top 5 Reasons Why Living Wills Won't Work for Alzheimer's and Related Dementias. The outline is that first we will talk about confidence in end-of-life planning and why that's important, what 2 questions living wills must answer, then we'll list and then go into detail of the 5 reasons why living wills won't work, and then an interactive part. The presentation will ask you, what do you conclude? What will you decide? Will you have enough confidence in end-of-life planning to decide on living? The conclusions, which we'll repeat yet later to see if you agree with them, are these. Not having confidence in your living will could lead you to consider and then act to end your life prematurely, since if your living will won't work, your dying could be prolonged with severe suffering. Yet, with the right effort, you can attain your goal, a timely dying, so this slogan will be apt. Plan now, die later to live longer. Most people have these as their end-of-life goals. Do you? To have a private, peaceful, and timely dying, and to avoid a prolonged dying with severe suffering, where timely means neither prolonged nor premature, and is based on your personal values, not what someone else thinks is in your best interest. Confidence in end-of-life planning is important to avoid 2 types of sad stories. A relative might say, let's not treat mom's pneumonia. Then we can be sure she won't suffer for years in advanced dementia like her mother did. This existential conundrum of concerned loved ones is commonly acted upon. A second is, if I don't kill myself now while I still can, then I won't be able to die later when I would want. Suicide is likely underreported, and this lament causes many patients daily anxiety, even if they would never take their own lives. It's called the Dementia Fear, which is if you have risk factors for dementia or a diagnosis of mild cognitive impairment or early dementia, you might fear, if I wait too long to kill myself, my dementia will progress and cause me to lose the ability to control when and how I die. I fear becoming stuck in advanced dementia for several years. It can lead to premature dying, and that can be tragic because the sacrifice of months to years of reasonably good living is unnecessary because there is an alternative. You can complete an end-of-life plan in which you feel confident that it will be effective, and then you can live until your suffering becomes severe. If you're concerned about a loved one, read this. Suppose you are a decision maker for a loved one now living with mid-stage dementia who no longer can make medical decisions, yet she still can enjoy the simple pleasures of life. Then one day she gets pneumonia. You could use this opportunity to make sure she will never reach advanced dementia. You could refuse all treatment. You could let her die. But life is worth living until suffering becomes severe. If you feel confident, end-of-life planning can help your loved one attain her end-of-life goals based on the criterion severe enough suffering, then what will you do? You will request a trial of full treatment that includes antibiotics for a reasonable time. You will give your loved one this better opportunity, the possibility to recover and to continue living. Living wills must answer these 2 questions if you no longer can speak for yourself. What treatment do you want? What treatment do you not want? And when will this be implemented? What and when? So the top 5 reasons why living wills won't work for dementia are: the what is not effective, the what is not acceptable, the when relies on criteria that are vague or irrelevant or dangerous, and the when uses criteria that physicians are not likely to consider compelling. Finally, advanced care planning did not include the extra effort to be convincing, to overcome physicians' resistance, or to prevent sabotage by others. The what is not effective. A what that stops all life-prolonging treatment is often necessary but not sufficient. I said all, but all is vague because sustaining the lives of many advanced dementia patients does not depend on high-tech medical treatment. They have no plug to pull. Living wills that request just vaguely stop all medical treatment may not allow advanced dementia patients to die. They must also make the specific request stop all oral intake of nutrition and hydration. An example, too many words on this slide, just briefly. The brochure from the Alzheimer's Association regarding end-of-life decisions strongly advises against tube feeding, instead careful hand feeding. And then if someone cannot swallow, approach is appropriate to focus on comfort in dying. They distinguish, quite rightly, that refusal or withdrawal of treatment, including tube feeding, is not assisted suicide or euthanasia. But their next recommendation is vague. Use advanced directive forms that are recognized in your state. Unfortunately, the brochure does not even suggest, does not even mention a living will that lets you refuse oral feeding by mouth, that is, to refuse spoon feeding. Suppose you do. It may not be acceptable. The withholding of oral food and fluid from a patient, even if the patient had clearly requested it previously, can lead others to view the compliance by others as euthanasia, which is illegal. Natural dying, which is the intervention that we propose in Caring Advocates, in contrast, only withdraws the assistance with hand feeding and hand hydrating. Natural dying always offers patients food and fluid. It does so by placing food and fluid in front of the patient and within reach. Natural dying, at best, can be viewed as allowing patients to die of their underlying disease at a time that is clinically appropriate, in a way that is legal and ethical and moral, and even consistent with the teachings of most major religions. The when criteria are vague, irrelevant, or dangerous. For example, the principle of proportionality, which is laudable and should always be followed by decision makers and reads as such: it is morally optional to discontinue a treatment if its harms and burdens outweigh its benefits. And the secular version is just a restatement of that more concisely. Yet applying this principle by itself to patients who are dying slowly is so vague that it often invites conflict that delays or thwarts attaining a private, peaceful, and timely dying. Behavior during spoon feeding might be irrelevant in 2 ways. If the patient resists spoon feeding, it might not be because she wants to die, but because she has severe pain in her GI tract, for example, a toothache, a mouth abscess, severe constipation, a bowel obstruction, and the patient cannot any longer tell others that she's suffering. Physicians who stop spoon feeding without looking for and then treating the cause of a patient's pain may let their patient die prematurely. Physicians need to be cautious and not presume that it is easy to judge what is in their patient's best interest. Another kind of behavior, if the patient seems to cooperate during spoon feeding by opening her mouth and swallowing what others put in, she may still want to die. The apparent cooperation during spoon feeding could be due to reflex, habit, wanting the last vestiges of social attention from others, or just reflect the patient's inability to show any kind of resistance because dementia has caused severe loss of functioning. If these or similar reasons apply, then the patient's dying could be prolonged, possibly with severe suffering that could increase. Again, Physicians need to be cautious and not presume that it is easy to judge what they feel is in their patient's best interest. It can be irrelevant also to reach a clinical stage or condition because patients may not be suffering. For patients who are not suffering but have reached a stage or condition of a disease, it would be arbitrary, irrelevant, or even worse. Patients may use this criterion of a stage to discriminate against their future selves. When they become an older person who has cognitive impairment, they may judge that their future demented self does no longer deserve to live. Many living wills use these terms that are vague and dangerous. I want to live until my quality of life becomes unbearably low or intolerably severely indignant. These terms could be dangerous because they could begin a slippery slope that may lead to one group of people presuming that they can judge whether the lives of others are or are not still worth living. History has sadly recorded the enormous harms that began in just this way. The most compelling reason to justify allowing a patient to die is irreversible severe suffering, and physicians may not consider anything else compelling. The challenge in advanced dementia is that patients cannot inform others if their suffering is severe at that time, and the physician's interpretation of what they observe as behavior could be wrong. The solution has two parts: to broaden the concept of suffering and to ask patients, while they still have capacity, to prejudge the suffering of well-described conditions. In addition to physical pain, suffering can include emotional or psychic turmoil, existential suffering, losing meaning in life and being able to relate to others, and not wanting to leave bad memories, suffering due to the disruption of one's life narrative, and not being able to spare loved ones the burdens of one's disease, which in turn leads to various types of suffering. Instead of asking physicians the clinical question, "Doctor, please evaluate this advanced dementia patient to determine if her suffering is severe now," a living will can have previously asked the planning patient this question: "Do you judge this condition would cause you severe enough suffering to want others to allow you to die of your underlying disease if you ever reach this condition?" Then the physician can be asked a much easier question: has the patient reached this clinical condition? Advanced care planning did not include the extra effort to be convincing, to overcome the resistance of physicians, or to prevent sabotage by third parties. Checking a few boxes on a form cannot prove that your decision-making process was diligent and deliberative, that you had sufficient mental capacity, that is, competence, as you express your request for end-of-life treatment. And checking boxes cannot provide you the opportunity to convincingly explain why you made your treatment preferences. So record your responses to an interview on video. Add, finally, to your advance directive specifically designed strategies designed to overcome physicians' resistance and to prevent sabotage by third parties. The strategies that we offer took years to develop with input from clinicians, bioethicists, attorneys, members of the clergy, and patients themselves. Basic rule in life: the solutions to complicated problems are rarely simple. I'll give you an example. Physicians can disregard living wills that request stopping oral feeding. Instead, physicians can write orders to continue spoon feeding until they interpret patients' behavior as refusal or distress. This actually happened in March 2019. A society of leading physicians who care for patients in assisted living and skilled nursing facilities and memory units voted to adopt a resolution to make this clinical decision paradigm as a guideline their policy. Strategies to overcome physicians disregarding living wills in this way include: interpreting refusal or distress may be wrong. It's ethically wrong to violate patients' autonomy and to violate the Patient Self-Determination Act of 1990. And it's ethically right to let patients choose who decides as based on their personal values as they complete their living will. To gain confidence in your end-of-life planning, either for yourself or your loved one, you can visit the website caringadvocates.org, which describes strategic advanced care planning for yourself and now care planning for your loved one. You can read or download the PDF 6 Steps for either one of these protocols that has more detail. I especially recommend Step 5 of 6 Steps to Strategic Advanced Care Planning, which introduces the strategy that strive to overcome more than 14 challenges and obstacles and exemplify what we've learned in practice that by itself, even the best living will may not be effective. In addition, case law further reveals that by themselves, proxy agents may not be effective unless they are backed by evidence and a clear and specific living will, which others can view as acceptable. So let's go back to the conclusions and ask if you agree now. Not having confidence in your living will could lead you to consider and then act to end your life prematurely, since if your living will won't work, your dying could be prolonged with severe suffering. Yet, with the right effort, you can attain your goal of a timely dying. To make this slogan appropriate: plan now, die later, to live longer. Do you have enough confidence in end-of-life planning to decide on living? Well, let's face it, end-of-life planning is not among the one of the two 100% certain things in life, like death and taxes. One authority is precisely what our planning effort tries to avoid: a lawsuit that leads to a court of appeals that legally sets a precedent. We much prefer this authority. Clinicians make decisions at your bedside, privately, in what we could call the court of clinical action. Do you have confidence that with sufficient effort you can attain your end-of-life goals? What will you conclude? What will you decide? Your choices are: I'm willing to sacrifice some years of living by preemptive suicide, or I want to plan now, die later, to live longer. To contact me, here's my email address, my phone, and text, which is good to alert me if something's urgent. I urge you to go to the website. This video, should you wish to recommend it to others, and these slides can be downloaded as a PDF. I have offices in San Francisco and Sausalito, but I provide counseling nationwide by a HIPAA-compliant internet interviewing application that can be used to record your testimony of your oral living will on video. Let me conclude by saying that I hope you don't need a living will, and that if you do, that it works for you, and that you don't need it for many years to come, and you have a good, healthy life between now and then. But if you put in the effort, you can enjoy life even more, because you no longer have to worry about a really miserable way to die.